So we have one more case in our ER, a 3-year-old child presenting with a history of fever, irritability, reduced appetite and headache for the past 1 day. So the last 1 hour, his mother has noticed non-blanging rash to his right upper limb. So you suspect that the child might be having meningococcal septicemia. Okay. So what could be the antibiotic choice in this condition?
Again, I have mentioned just like the meningitis caused by meningococcal Neisseria meningitis. Here also the drug of choice remains ceftriaxone 80 mg per kg. We'll have to give drugs.
Okay, so give me some features in presentation which is suggestive that the patient can have a very poor prognosis of the condition.
At the time of presentation, if the child is having very low GCS, if the child is having severe acidosis, or the patient's peripheral total count is, it's in the neutropenic side, that is in the total count is very less, the patient is having some coagulopathy, thrombocytopenia, and the features of meningism is absent. Such features all suggest that there is a very bad prognosis.
Okay, fine. So as you told, Neisseria meningitis is a gram negative. Is it a aerobic, encapsulated diplococci? It mostly colonizes in the human nasopharynx and is transmitted through the droplets. So there is high chance that patient can have increased manifestation of the same disease. So there is high chance that the carriage rates for the same disease is also very high. So as we are discussing, when a patient with less than 5-year-old age group comes to the ED, there is a chance that patient can have similar like Neisseria meningitis induce either a meningitis or probably a septicemia. At the same time, the peaking of the disease is probably like around 15-19 years. Why we are concerned about this thing is, as we told, the case fatality ratio is mainly when the patient reaches at the age of like around 15, and there are 2 groups of people which should be considering the case fatality ratio is high. That is, one is the age like around 15 and one is less than 1 year old. Yes, and there is a significant seasonal variation in this condition because mostly we find all these conditions or manifestations mostly in the winter season, right? So these are some of the points, and we know what are the possible features of septicemia. So I would like to ask you, what are the possible features suggestive of meningococcal septicemia?
The meningococcal septicemia, the most important feature is the presence of rashes. That is, in presence of non-blanching rashes will be there. And other than that, the features of septicemia is more of shock-like characters rather than in while we
it mainly involves a circulatory compromise.
In meningitis, we were dealing more of neurological issues. Here, the child will be having mottling. The peripheries will be dry, dehydrated, and the patient's mottled up, mottling, dehydration.
Rash will be there. So because of the circulatory compromise, patient can have confusion, altered mental status, signs of clinical shock, neck stiffness, everything can be there. So talking about features such as meningococcal meningitis, so patient can have the most important sign, as we told, even though they have classified as early signs and late signs. So early features are mainly involving fever, irritability, lethargy, respiratory complaints and vomiting. That is typical of any meningitis. So the late features which we have to consider is, one is bulging fontanelle, that is the most important sign, and the thing is, second thing is like petechial rash, which is very peculiar of meningococcal meningitis, altered mental status, neck stiffness and headache. So these are some of the signs which we should consider regarding clinical manifestation. So talking about management, we all know what all investigations, what we are supposed to do in meningitis. So tell me something about the general management of septicemia in this case.
Again, first and foremost, here we will have to correct the shock. So fluid resuscitation with initial 20 ml per kg of fluid resuscitation should be.
So there is a difference between fluid resuscitation in DKA and septicemia, isn't it?
Yes, DK we initially start with 10 ml per kg.
Yes.
Here, as per just treating all other shock, we have to start with the 20 ml
20
per
ml
kg.
per kg. Okay.
Again, 1 more shot of 20 ml per kg can be given as a ED physician, but beyond 40 ml per kg, we should take a pediatric intensivist consultation.
Yes.
And then next important thing is to receive the antibiotic as early as possible. Before that possible, we should get the blood routine investigations along with the cultures. And again, the drug antibiotic of choice, if it is for more than 3 months, is again ceftriaxone,
Yes.
80 mg per kg. If it is less than 3 months, it becomes cefotaxime plus ampicillin.
Ampicillin to cover Listeria.
Listeria.
Okay.
We'll have to.
Okay. Do you have to give any steroids in this case?
Again, meningococcal septicemia, we'll have to give steroids again, 0.15 mg per kg Dexona, but 4 times a day, but we'll have to give up to 7 days.
Tell me something about the peripheral inotrope of choice in this condition.
In meningococcal septicemia, just like in sepsis, we'll have to first start on dopamine. Okay, for RCM, we are suggesting RCM, dopamine to start as inotrope, and as a second line, we can start up to adrenaline can be given. And regarding steroids, I forgot to mention that steroids are recommended when even after initiation of first inotrope, the patient have features of shock.
That is a refractive shock to inotropes.
Then you are supposed to start the steroids.
So the golden period is, what is the golden period?
Within 1 hour.
Within 1 hour, 60 minutes.
60 minutes. And one more thing, if it is less than 3 months old baby, steroids are not recommended.
Yes. So these are some of the features. So you have corrected the shock, and there are, as we told, coagulopathy is a regular feature of meningococcal septicemia. So how do you correct coagulopathy in this case?
If associated coagulopathy is there, then we have to check the fibrinogen, and if it is less than 1 gram per deciliter and all, we will have to give FFP and cryo. If you are giving FFP, 10 ml per kg can be given. Cryo, if you are using, we have to give 5 ml per kg.
Yes. What about HP, hemoglobin?
We target an hemoglobin more than 10 grams per deciliter.
Okay. So these are some of the things which has to be done. And again, one major complication against cerebral edema. We know how to manage cerebral edema, isn't it? So give me 2 drugs which are used to manage cerebral edema.
Again, we will be using mannitol and 3% saline.
Yes.
We are using mannitol. Then again, the dose is 0.25 to 1 gram per kilogram can be used, and over 10 to 15 minutes bolus should be given. And if you are using 3% saline, again dose becomes 2.5 to 5 ml per kilogram. 3% saline again to be given over 10 to 15 minutes.
What about like positioning the patient regarding oxygen and carbon dioxide requirements and all in a patient with cerebral edema?
In cerebral edema, this is to reduce the raised ICT.
Yes.
It is better to feed the baby in the head and elevated posture, and keep it.
It should be in the
midline.
Yes.
And to maintain a normal PCO2 or in the normal limit of PCO2, and to maintain a normal oxygen.
Fine. Anything to be told about IJV access?
Necklines. Avoiding necklines will help in having a proper venous return, so it's also helping further aggravating any cerebral edema. So
the certain things which has to be done in a case of cerebral edema or raised ICPs. One is you maintain a proper temperature, so prevent hyperthermia or hypothermia, prevent hypoglycemia or hyperglycemia, prevent hypoxia, hypercarbia or hypocarbia. Next thing is seizure prophylaxis. So, and the next thing is the possibility of adding upon antibiotics, and in case of any requirement for surgical intervention, you have to take it as early as possible. So these are some of the things which we have to remember when we encounter cases of raised intracranial pressure. Right. So talking about seizure management, suppose a patient is seizing currently, which is the drug of choice in that case?
Just like all drugs, benzodiazepam, lorazepam, 0.1 mg per kg should be used.
Okay.
If you are using diazepam, buccal or rectal diazepam to 5 mg per kg.
In case like we don't have IV line, isn't it? Okay. So what about paraldehyde?
0.4 mg per kg of paraldehyde per rectal can be
used. Yes.
Then if you are using thiopentol sodium 4 ml per kg, but in that scenario the patient has to be intubated.
Yes. So that is the last drug of choice in case of active persistent seizures. So first you start with the benzodiazepine as Dr. Riaz told, you start with a lorazepam, and then probably you have to go for a paraldehyde, and after which we go to the mainstream of anti-epileptic agent in the form of fosphenytoin and phenytoin, that is 18-20 mg per kg over a period of around 45 minutes, 30 to 45 minutes, and still the patient is seizing. Then you have to go step on to the hike up the anti-epileptic to thiopenton sodium like around 4 mg per kg, and then you have to consider the patient will be like intubated and promoted to ICU stay. So these are some of the things which we have to consider when a patient comes with raised intracranial pressure as a complication of meningitis. And we've discussed the poor prognosis features like if the patient has presence of shock, absence of meningitic signs, presence of coagulopathy, thrombocytopenia, and low blood count, etc., and a proper purpuric progressive rash, and with depressed mental status and all. These are some of the poor prognostication features. And regarding prophylaxis, three groups of people will require prophylaxis in the form of household contact within 7 days, any healthcare workers within 24 hours, and definitely intimate people with the patient. Right. So this ends our discussion about our today's session of FRCM discussion of questions. We have mainly 3 cases, which has been, one is DKA, the second is meningitis, and third is we have discussed about meningococcal meningitis and meningococcal septicemia. Thank you.